Episode 43, Persistent Lower Leg Pain in a Runner. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. The patient today is a 28-year-old healthy nurse. She is a female, and in April of 2016, she woke with pain in her right shin and hip. She attributed this pain to an increase in her exercise frequency and intensity. Her recent exercise included running up to 60 kilometers per week in her free time, in addition to aerobic and weight exercises. When her pain worsened, she presented to the emergency department. The signs and symptoms were consistent with acute inflammation over the medial tibia, and she was diagnosed at that time with cellulitis and treated with a course of oral flucloxacillin. I was unfamiliar with that antibiotic, but flucloxacillin is the most common narrow-spectrum penicillinase-resistant penicillin used in the United Kingdom, where this case study was reported. Over the next 3 months, she received 3 separate courses of oral flucloxacillin for persistent inflammatory symptoms and suspected cellulitis, with little clinical improvement and persistent pain over the tibia. She remained systematically well, and her inflammatory markers were within normal limits over this period of time. Her past medical history was notable for a recurrent lower right wisdom tooth issue that had been treated with antibiotics about 6 months earlier. The physical exam was very limited in this case study. They noted a body mass index of 21, and she was described as athletic and lean. My differential diagnosis: stress injury to the bone, medial tibial stress syndrome, bony pathology including malignancy, and soft tissue infection. I want to recognize the authors. This article was published in 2018 in the British Medical Journal of Case Reports, and the authors included Hammad YN and Norrish A out of the Trauma and Orthopedic Surgery Unit in Cambridge of the United Kingdom. I am Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in November of 2026, and I hope you will join me on the journey. This podcast is for educational purposes only. Okay, so in June of 2016, imaging was finally obtained. Plain x-rays of the right tibia showed a well-defined linear lucency in the mid-tibia with marked anterior tibial periosteal reaction. An MRI was obtained with findings suspicious for osteomyelitis in the middle third of the tibia. In July 2016, a bone biopsy was performed with cultures growing 2 organisms, Aggregatibacter and Streptococcus malariae. Both are oral pathogens, and Aggregatibacter is part of the HASEC group of organisms, a group we associate with culture-negative or slow-growing endocarditis. A transthoracic echocardiogram demonstrated, fortunately, no valvular vegetations. The authors concluded that there was hematologous seeding of the tibia from her oral cavity. The infected focus in the right tibia was surgically debrided, followed by 6 weeks of IV antibiotics. She completed antibiotics in December of 2016, so roughly 8 months after symptom onset to the completion of treatment, and has remained symptom-free since. A couple of key takeaways from me. The authors propose a convergence of factors in an otherwise healthy young adult which led to a diagnosis of osteomyelitis. First, there was the mechanical piece. Her high training load produced what the authors felt was initially medial tibial stress syndrome. The microtrauma and associated periosteal reaction in the tibia likely created a connection between the bone and the systemic vasculature, essentially exposing the bone to circulating oral pathogens. Second, there was the seeding component. In this patient, there was a recent recurrent oral infection as a potential source of bacteremia with a vulnerable bone bed. The third factor, as the authors note, was the host. The authors point to relative immune compromise from a combination of heavy exercise and an active weight loss regimen in this particular patient. A question I had when I read through this is why this individual received 3 separate courses of oral antibiotics for suspected cellulitis without improvement. A non-resolving infection should trigger further investigation and imaging rather than another empiric antibiotic course. The authors note this is a single case report and that the incidence of osteomyelitis complicating medial tibial stress syndrome cannot be estimated, and the overwhelming majority of medial tibial stress syndrome resolves spontaneously with relative rest. I want to focus a little bit more on medial tibial stress syndrome for my exam. So medial tibial stress syndrome, commonly called shin splints, is an overuse injury causing exercise-induced pain along the distal 2/3 of the posterior medial tibial border, driven by bone overload where cortical bone resorption outpaces formation. It is among the most common causes of exertional leg pain in runners, dancers, and military recruits. The diagnosis of medial tibial stress syndrome is primarily clinical. It is exercise-induced pain reproduced by palpation along the posterior medial tibial border over the span of equal to or greater than 5 centimeters. It is, by definition, diffuse rather than focal. Imaging is usually deferred for persistent cases, and meta-analytic data support the following risk factors for medial tibial stress syndrome: increased body mass index, greater navicular drop or overpronation, increased ankle plantar flexion, increased hip external rotation, female sex, and of course a prior history of medial tibial stress syndrome. The cornerstone of treatment is relative rest and activity modification. In controlled trials, no intervention has clearly outperformed this intervention. Extracorporeal shockwave therapy is evidence-based and may shorten symptom duration. Foot orthoses, when part of a conservative program, have been shown to produce early reductions in pain and severity. There is a potential surgical treatment of a posterior fasciotomy, but this is rarely needed and reserved for refractory cases. I've never needed to go to that point in individuals I've taken care of. And in 2025, a meta-analysis found neuromuscular training demonstrated high certainty evidence, and overpronation control insoles demonstrated moderate certainty evidence in reducing the incidence of medial tibial stress syndrome. Other interventions studied in this meta-analysis included shock-absorbing insoles, static stretching, and special socks. Those interventions were not supported by the evidence. Neuromuscular training for medial tibial stress syndrome prevention refers to supervised programs that train movement control, muscle coordination, muscular strength, flexibility, and gait mechanics with real-time biofeedback as a treatment option. This does not include passive interventions like stretching and shock-absorbing insoles. Okay, moving on to questions. Question 1. An 18-year-old female collegiate soccer player presents after doubling her preseason training volume over 2 weeks. She reports aching pain along the inner aspect of both shins that comes on during running and lingers for a few hours afterward. On exam, she has diffuse tenderness over roughly 7 centimeters of the distal posterior medial tibia bilaterally. There is no focal point tenderness, a negative hop test, and no skin changes. What is the appropriate next step? A. Immediate MRI to exclude stress injury. B. A clinical diagnosis of medial tibial stress syndrome and relative rest with activity modification. C. Intracompartmental pressure testing. D. Empiric oral antibiotics. The answer is B. The history and exam with a negative hop test are classic for medial tibial stress syndrome, which is a clinical diagnosis. Relative rest and activity modification are the cornerstone of treatment, and advanced imaging is reserved for atypical features or when stress fracture is suspected. Question 2. A 20-year-old male distance runner is diagnosed with medial tibial stress syndrome 3 weeks ago. Despite relative rest, he returns with pain that has become sharply localized to a single spot on the tibia and now occurs at rest and at night. On exam, there is focal point tenderness over a 2 centimeter area and a positive hop test. What is the most appropriate next step? A. Continue conservative management and reassurance. B. Obtain plain radiographs. If negative and suspicion persists, obtain an MRI. C. Begin extracorporeal shockwave therapy. D. Refer for fasciotomy. The answer is B. The evaluation is suspicious for stress injury, and further investigation with imaging is recommended. Radiographs should be obtained first, and they may be repeated or followed by an MRI. Question 3. A 23-year-old military recruit describes leg pain and a sensation of tightness that begins predictably at about 10 minutes into every run, forces him to stop, and then resolves within several minutes of rest. Between runs, he is asymptomatic, and tibial palpation at rest is non-tender. What is the most likely diagnosis and the most appropriate confirmatory test? A. Medial tibial stress syndrome confirmed by plain radiographs. B, tibial stress fracture confirmed by triple phase bone scan. C, chronic exertional compartment syndrome confirmed by intramuscular compartment pressure measurements. D, osteomyelitis confirmed by bone biopsy. The answer is C. Exertional pain and tightness that recur at a reproducible workload, resolve quickly at rest, and occur with no pain at rest point to exertional compartment syndrome rather than medial tibial stress syndrome. The diagnosis is confirmed by compartment pressure testing. Commonly cited thresholds for compartment pressure testing include a greater than or equal to 30 millimeters of mercury at 1 minute or greater than 20 millimeters of mercury at 5 minutes post-exercise, though there are other thresholds that have been argued. Question 4. A collegiate track coach asks which measures will best reduce the incidence of medial tibial stress syndrome in his runners. Based on the highest certainty evidence, which recommendation is most appropriate? A. Issue shock-absorbing insoles to all runners. B. Add a supervised neuromuscular or gait training program with overpronation control insoles for those who overpronate. C. Prescribe daily static calf stretching. D. Provide compression socks for training. The correct answer is B. A 2025 systematic review and meta-analysis found neuromuscular training reduced medial tibial stress syndrome incidence with high certainty, and overpronation control insoles were effective with moderate certainty. Shock-absorbing insoles, static stretching, and special socks were not effective. Thank you.